everyone. Today's talk is about obesity evaluation and management. This is Dr. Fozia Akhtar Ali. I am one of the graduates from Allama Iqbal Medical College, Lahore, Pakistan. I am faculty at UT Health, San Antonio, Texas, where I teach the family and community medicine residency program, and also I'm diplomat of American Board of Obesity Medicine. So the reason I chose this topic, because this is very high yield and especially for primary care and also all the other specialties. So today we will talk briefly about the obesity. The reason I said briefly, because this is a broad topic. We can talk for hours on this topic, but I want you to have some basic concepts. Your exams, and especially being in the medical school, you need to know how to diagnose, how to evaluate obesity, and also you need to know the basics of the weight management. So today's learning objectives after this activity, you should be able to understand the pathophysiology and risk factors of obesity. You will be also able to discuss the tools required to diagnose obesity and learn about basics of weight management. So let's first talk about the obesity definition. The definition of obesity is broad, and if you look at the different resources, the definition is very broad, but at the same time very diverse. It's important to understand how you define the obesity in order to diagnose. Obesity Medicine Association defines obesity as a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. There are a few other definitions for obesity. Obesity is also defined as excess of body weight resulting from accumulation of body fat over time because of excess of energy intake or a lack of energy expenditure. So this definition tells you, like, if the increased food intake excess calories, or if you move less or you have less physical activity, that can result into obesity. Clinically, if you define obesity, it is actually having an increased BMI, body mass index, which is also very much different based on ethnic background. Besides the body mass index, which is very commonly used in clinical settings, we also use some other measures to define and to diagnose obesity. One of them is waist to hip ratio, which I will talk in next slide, waist circumference, which is different in male and female, and body fat percentage. So those are the very important tools you need to remember when you evaluate the patient with obesity. So on this slide, on the left-hand side of the slide, if you look at the BMI, it's basically, it defines if there is overweight or obesity range. So it's very important to not to ignore the BMI of overweight range. So BMI of 25 to 29 are usually, we say if BMI is above 27 in Asian, so that is somewhere you start worrying about obesity as a risk. Let's talk about the classes of obesity. It's very important to know how you define the class 1, 2, and 3 of obesity. So BMI ranges really help you to define the class 1, 2, or 3. BMI range of 30 to 34.9 puts obesity in class 1. BMI of 35 to 39.9 is class 2, while BMI of above 40 is class 3, or also called morbid obesity. The other most important thing, which it's very uncommonly used in clinical settings, but is very important not to miss, is body fat percentage. So body fat percentage recommendation vary between men and women, and also between the different age groups. For example, if you're seeing a 30-year-old female coming to your clinic and asking like, what is my recommended fat percentage? So this slide helps you to answer the question. So you will recommend a woman that your fat percentage should be between 23 to 38%. That means if the fat percentage goes above 38%, the risk of being overweight and obesity goes higher. This is a very high yield topic, the metabolic syndrome, that you all need to know, especially during your medical school education, because the early diagnosis is the key. So metabolic syndrome has the certain category, and I will go over this because this is very important for you to learn. So as I mentioned earlier, the waist circumference is a very early sign of the obesity risk. So for example, if you look at a patient and then they meet the criteria of these measures, then the diagnosis would be metabolic syndrome. Let's look at the waist circumference. So it's different in male and female. If the waist circumference is above 88 in female, above 102 centimeters in male, then you look at the triglyceride levels, and that is going to be on the lipid panel. So triglyceride above 150, that would be the risk, or if the patient is on medication to lower the triglyceride. The third thing on this criteria is to look at your healthy cholesterol or high density lipoprotein cholesterol. So this would be a criteria for diagnosis of metabolic syndrome. And most patients with type 2 diabetes will actually meet this criteria. So that is also an indication of early intervention and close follow-up. Obesity is a disease. It's very important to know this because then you can educate your patients very well. So in understanding as a disease, when you look at the disease, how the disease presents, it presents with signs and symptoms. The disease also impairs your normal function, and also it puts you a higher risk of other conditions and increased morbidity. So if you look at the obesity alone, what happens? It actually impairs physical activity. You also have altered physiological function because you develop insulin resistance, dyslipidemia, or hyperlipidemia. And also regulation of the satiety will be altered in these patients. The signs and symptoms, some of the very common sign and symptom with obesity that we see a lot in clinical settings is joint pain, osteoarthritis, impaired mobility. Patient is not able to walk. They have low self-esteem. They may also develop sleep apnea, which is a condition very commonly associated with obesity. And they also have altered metabolism. It is also associated with other cardiovascular diseases, type 2 diabetes, metabolic syndrome, increased risk of cancer, and death. So as with other chronic conditions like diabetes, hypertension, high cholesterol, obesity needs special attention to be managed the same way as we manage the chronic disease. encourage the regular physical activity. The secondary prevention is basically you are trying to prevent the future weight gain and development of weight-related complications in patients who are diagnosed as overweight or obese. So you start looking at the BMI. You also treat with a lifestyle and behavior intervention, and you can also add weight loss medication. Tertiary prevention is very challenging because you have to have a multidisciplinary approach, and that is very intense lifestyle behavior interventions and also weight loss medications. You can also consider weight loss surgery or bariatric surgery as a tertiary prevention method. This is very important clinically. I want you to all know that what terms you should use with your patients and what terms you should avoid using are discouraged terms when you are seeing a patient. So very importantly, when you see a patient who you look at the BMI and diagnose with obesity, try not to use the term obese, morbidly obese, or fat. Try to use the terms like weight, abnormal weight, unhealthy weight, overweight. Body mass index is a great way of using the terminology. And also you can use the word affected by obesity. This is very important because if you're using one of the discouraged terms, you are actually also affecting patients' self-esteem. So obesity has several causes and risk factors. We will talk about some of the extra genetic causes. Environment plays a significant role in obesity. The studies have done showing like if the family members that can also cause weight gain. So a normal quality of sleep is very important. A lot of times we need to know that what medications your patient are taking. If some of the medications can also cause the risk of weight gain. So you need to work with your patient to change those medications. Stress is another risk factor. Neurological dysfunction, like the trauma, brain trauma, or hypothalamic inflammation, leptin resistance is one of the cause. Viral infections, gut microbacteria, and also there's a lot of other causes that not on the slide that you need to find out any other psychosocial factors, financial stress. So it's very important to look at the underlying cause while you are treating the obesity. You need to discuss with your patient early on what can be complications caused by abnormal weight or increased weight. As we discussed earlier, it can put you increased risk of metabolic syndrome, impaired fasting glucose, and diabetes, hyperlipidemia, hypertension, cardiovascular mortality, and non-alcoholic fatty liver disease or hepatic steatosis is one of the risk factors as well. In female, this can increase the risk of polycystic ovarian syndrome. Obstructive sleep apnea is very common in patients with obesity. Asthma or reactive airway disease, you also see a lot with obesity. With increased weight gain, gastroesophageal reflux disease is very common. Depression, low self-esteem, you can also see a lot. to diagnose. Sleep pattern is very important to ask questions about the sleep. How is their quality of sleep? Is their sleep affected? Is there any mental stress going on? Is there any recent surgery or surgical history? Looking at the medications, if they are taking any medication causing weight gain. If they have any food allergies and they cannot eat healthy food because they're allergic to some of the food. Smoking, alcohol, and drug abuse, those is very important to ask. And looking at not just the BMI, but also looking at the percentage body fat, waist circumference, neck circumference. Those are one of couple of physical exam findings you need to evaluate. Family history is very important. You need to also ask your patient about the support system. Because if they don't have a good family support, then that's going to be a challenging journey towards weight loss. Socioeconomic history. There may be a financial stress going on. And cultural history is very important. In terms of nutrition history, you need to get a detailed nutrition history to evaluate patients with obesity. So let's look at the meals and snacks. So you need to ask about how many times a day they are having meals. They may be skipping breakfast. They may be eating dinner very late at night. And also you need to look at the nutritional density. How dense is, how rich is their meal? Who is preparing the meal? How do they have access to healthy food? Also, it's very important to ask them if they're eating and they're watching TV, because that can also increase risk of weight gain. If they're eating out every day, out in restaurants, and if they're going culture, like if they are having their plate full and then they have to finish the meal, that's another thing you need to make sure discuss with your patients. If they're ready for change, and that's the most important thing, before you talk about obesity, you need to assess if your patient is ready to make changes. You also ask them to give you a food record, like 24-hour recall. What did they eat yesterday? Breakfast, lunch, dinner, any snacks? What were the drinks? Water intake. You can use a lot of electronic apps now. They're free apps on the phone, smartphones, and they can use and they can track their food there. They can keep a diary. They can write it down. So it depends on the patient's preference. That is a key technique to work on the weight management, to track what you eat. Because if you track what you eat, you'll be more mindful. So this slide shows you basic calorie recommendations for weight loss. As you see here, women 1200 to 1500 kilocalories per day. For men, 15 to 1800 kilocalories per day. Very low calorie diet is calories less than 800 kilocalories per day. And for BMI above 30, but we would not recommend this because very low calorie diet actually puts you at high risk of electrolyte imbalance, liver function changes, gallstones. So you should not be recommending a very low calorie diet to your patients without close observation. This slide gives you an idea of how you educate your patient in terms of nutrition. So you have them limit the high processed food. For example, junk foods, cakes, also high fiber food versus low fiber food. The most important thing that we need to practice in our daily routine is to read labels. If you buy food from grocery store, to look at the labels, and then to look at the carbohydrate, the fat percentage, protein content in that nutrition label. So managing the quality of calories is very important when reducing the quantity of calories, such as during the weight loss period. So let's go over some calorie diet. So as I mentioned earlier, very low calorie diet, less than 800. You don't recommend on daily basis. It requires very close physician supervision, and also this is only used for short-term duration. So low calorie diet is acceptable, and that can help in weight loss. So in low calorie diet, you can either recommend your patient to restrict the dietary fat, because then that will also help to reduce their total and their LDL cholesterol. They can start with having less than 30% of total kilocalories from the fat, or you can also have them restrict dietary carbohydrates. And that will help in reduction of serum triglycerides and increase your HDL. This will also help to reduce the serum glucose and hemoglobin A1C, and thus have a better control of diabetes. So this is another way of engaging your patient in working together to reduce the dietary carbohydrate. At the same time, you don't want to recommend to have a very low carb diet, because that's not also very safe. You need to have some carbohydrate on daily intake of carbohydrate. So that's very important to have them switch from simpler carb to the complex carb or a high fiber food. So working through your patient on the weight management, there are some key recommendations on this slide. And this is a very important to have set up a goal with your patient. You have them lose 7 to 10% of their body weight, but you don't have them have a bigger goal. So SMART goal is a key. The goal that you discuss with your patient should be specific, it should be measurable, it should be achievable, and realistic and timely. And that is a key. So you have them aim for 1 to 2 pounds per week for a period of 6 months. You can bring them back. You should bring them back every month and discuss over their goals. The goal can be low calorie diet, reducing the fat as a part of low calorie diet. But then also reducing the fat alone without reducing the calories is not sufficient for weight loss. Then you should be individualize the dietary plan. The diet plan can be different for your patient who has high blood pressure versus a patient who has diabetes or who has history of gout or history of renal disease. And you also can help them create a deficit of 500 to 100 kilocalories per day. At the same time, the physical activity is very, very important to discuss. And that's a part of the comprehensive plan. You need to have behavior therapy for your patient, a dietitian visit. So this is a multidisciplinary approach. And as a physician, it's very important to keep your patient involved, have them part of the team, because this is a long journey, and really keeping their self-esteem is very important. If you see a patient and bring them back in a month and they are not able to lose weight, as you set up a goal a month ago, you should still encourage them that they are not gaining weight, and that is a success as well. This will increase their confidence and help them in their journey towards weight loss. So this is an example of lifestyle therapy. So you discuss with your patient their meal plan, reducing their calorie count, If your patient is not able to get up and walk, you can discuss the chair exercise, and that's going to be small step. Behavior modification is very important in treating obesity. So you need to have your patient self-monitor or log or keep track of their food, their exercise, and their weight. You need to set a goal at every visit. Educate your patient, help them overcome the barriers, and also help them work on coping mechanisms for stress. Psychological evaluation is very important, and this will be a motivational interviewing at every visit. And most of all, the social support and family support is very important. Weight loss medications can also be used if BMI is above 30 or BMI more than 27 with comorbid conditions. Weight loss medications alone will not work unless you combine them with behavior modification, physical activity, and nutrition for optimal result. And that is very important to discuss with your patient, that not to just expect the magic results from weight loss medication. You need to have them work on all the other interventions with the medications. If you start someone on weight loss medication, bring them back and they're not able to lose weight, they're not responding very well, then you need to stop the medication. You can add more than one medication if one does not help. Weight loss surgery is also as a last resort if the patient's BMI is above 40 or above 35 with and they will not be a candidate for surgery unless they have attempted medical weight loss treatment without success. So it's very important to have your patient know this before, that they may be asking you to recommend them weight loss surgery and have them see bariatric surgeon. But you need to discuss with them that they need to attempt medical weight loss and they need to work on the diet and physical activity before they will be a candidate for surgery. And there are a lot of complications also from the surgery. So who is not a candidate for weight loss surgery? There's some relative contraindication, someone who has history of substance abuse, eating disorder, or major psychiatric problem which is untreated or unresolved. If the risk of surgery outweigh the benefits, then you would not recommend that. Women who are planning to become pregnant within 12 months are not a candidate for weight loss surgery. It's very important before the surgery, you need to have a pre-op or pre-operative medical assessment. And that will be a medical evaluation by obesity specialist, mental health assessment, assessing for eating disorder, mood disorder, substance abuse, suicidal risk. Dietitian need to see the patient also for nutritional assessment, and there should be an educational support system for your patient. These are some of the bariatric surgical procedures. Gastric bypass, we also call it Roux-en-Y, is one of the procedure. physical activity plan, and also behavior health. And this will be a long journey with your patient. So you need to have a close follow-up and really bringing up their confidence higher. These are some of the references from Obesity Medicine Association, American Academy of Nutrition and Dietetics, and also obesity treatment guidelines. So if you have any other questions, please email me and I will be happy to answer your questions. Thank you so much. Have a great